Good morning, everyone. I'm Marjani Cephas, the Sickle Cell Disease Program Specialist here, and works closely with the coalition under the Center of Sickle Cell Disease Initiatives. Gosh, I need my coffee. Um, and this is our second session of our peer learning exchange, which is a collaborative platform designed to foster shared learning, innovation, and capacity building. So we have a very special presentation from the Clinton Health Access Initiative, CHI, and we are looking forward to hearing more from them shortly. And I'm going to pass it over to Paul, who is our Global Perspectives co-chair, but also works for CHI. So I'll let you introduce Melissa and Melinda, as well as yourself.
You bet. Okay. Hi everybody. I see people coming in as we launch, so that's great. I'm Paul DeMonico. I am a Global Health Research Fellow at CHI. I'm also the co-lead of our sickle cell disease program. And it's wonderful to see all you. And I'm glad that this is recorded because I know a lot of people wanted to be here, but had conflicting calendars. Um, I'm very briefly going to make a few statements and hand it over to Melinda and Melissa so that they have as much time as possible. Chai has extensive experience in the area of market shaping and has achieved a number of successes in the infectious disease areas, as well as non-communicable diseases and conditions. Um, and today, Melinda and Melissa will give you an overview of Chai, so you get a better understanding of who we are and how we do our work, and talk through an integrated approach, both technical and strategic, helping to accelerate equitable access to quality assured medicines. And through their presentation, they will demonstrate how Chai works across many partnerships to co-create and implement a sustainable strategy. And we'll wrap up with one or two case studies. So over to you, Melinda and Melissa.
Thanks, Paul. Just to start off with introductions, and then we'll get into the presentation. Hi, everyone. Glad to see such a robust group here. My name is Melinda Watkins, and I'm the Senior Director of the Product Development, Quality, Costing, and Regulatory Affairs team at CHI, or PICRA, as you see on the screen. Happy to be here to present kind of the work that we do at CHI. It's very cross-cutting in nature, and as Paul mentioned, we'll go through how we do that and also provide some case studies. But before we launch into that, Melissa, do you want to introduce yourself?
Yes, hi everyone. Melissa Levitt. I am a director on the PICRA team working with Melinda on all of these really fantastic and exciting programs that we do at CHI.
All right. And with that, I guess we'll go into the presentation. We will have time for Q&A at the end. So happy to take any questions that may come up. So today we built this presentation around these learning objectives. We wanted to introduce CHI. You may be aware of CHI or through the work that Paul is doing with your organization, know some about what we do, but we wanted to dive in about CHI and how we work, and then dive deeper into our market shaping framework, which is really the basis under which we work across the teams and across disease areas, and talk about what those dynamics look like when we are launching programs. And then we do have a couple of case studies at the end to show how a market shaping framework was applied, both for an HIV PrEP product as well as for sickle cell disease. Next slide. So, as I said, you may or may not be aware of CHI and the work that we do, but we're a global health organization that operates at the nexus of government, business, and health. And really, I think the key component here at CHI is our trusted relationships with governments in the countries in which we work. And therefore, we're able to provide on-the-ground assistance to governments based on their own priorities, and then move that back up into what we call the global teams so that we can all operate at the behest of the governments. Next slide. So our vision is a world in which everyone is able to live a healthy and fulfilling life, and our mission to save lives and improve health outcomes in LMICs. And we do this by enabling government and private sector to strengthen and sustain quality health systems, which also then incorporates quality assured medicines, which is what we will talk more about today. So here's just some stats about CHAI and what we've done over the years. We are over 20 years old now, founded in 2002. We are in 35 countries, and really a large percentage of our staff are country nationals and take leadership roles as well. We've done hundreds of deals, which we'll go into a little bit more now. And we try and provide as broad access as possible to the deals that we do negotiate, which are largely price driven for key commodities that are required for the various disease areas in which we work. Next slide. So the way that we do this is really, we have these various buckets of the work that we do: market shaper, which is what we will dive into today; trusted strategic partner; operational partner; the nexus of which is ecosystem catalyst. And so we work across these buckets to develop holistic solutions to the problems that our countries face with healthcare commodities, and overall programmatic support. Next slide, please. So diving into the market shaping framework, this is something that has been developed over many years. It has been developed in collaboration with partners, with governments, and it's really, the key here is that we want to create sustainable marketplaces. We understand that on the business side of things, the suppliers of the products have to turn a profit, essentially, to remain in business, and therefore be able to provide the medicines that are crucial for our programmatic areas. And on the flip side of that, the products that they produce have to be affordable in the countries so that those products are actually utilized and do get widespread adoption. So we have basically, 6 buckets here, starting at the earlier end of the spectrum of, drug or product development. To accelerate that development, we want to achieve sustainable access pricing, which is affordable pricing for our countries. To do that, you have to generate demand among governments and end users so that there is a market to be had. And we want to make sure that anything that we are producing or working with suppliers to produce has the appropriate functionality, safety, efficacy, et cetera. We want supply security to be enhanced such that there aren't stockouts or gaps in the market. And we're always wanting to improve product quality so that we meet internationally recognized standards, and so that the medicines that you receive in our countries would be the same as you would receive anywhere else in the world. So this results in a matrixed framework, which will be on the next slide, to kind of have a balance between supply and demand. And that is supply, making sure that the suppliers are in the market; demand, making sure there's a market for them to have so that they do remain in business. We've got, 5 different areas that we look at with this framework. And then we have the categories underneath, which we will dive into a bit more deeply in the next slides. So what we'll focus on today is talking a little bit about the barriers or preconditions to LMIC access. It's a pretty specific area, a little bit different than drugs that are developed for high-income countries and the needs in LMIC. And we're going to focus in on what my team does, which is on the research and development, regulatory and normative, and manufacture and commercialization side of things, which is much earlier in the process to get products ready for launch and ready for commercialization. Next slide. So within those three buckets that we will focus on today, we've listed here some of the barriers or preconditions to consider when developing a program and therefore ultimately providing access. I won't read through all of these, but these are things that we have identified over the years that need to be addressed early in the program so that you can have a very smooth transition along the life cycle from R&D through the regulatory or normative processes, depending on what disease area you are working in, and through to manufacture and commercialization. Things don't stop with regulatory approvals. Things need to move forward to make sure that there is actually new product introduction on the commercialization side of things. Next slide, please. So then moving on from the barriers, what are the interventions that we use to address those barriers? Again, in these three buckets that are relevant to the work that my team does. Next slide. So here is where we have tried to come up with things that may mitigate these barriers, reduce risk perhaps, and things that could be employed in any given program. You know, some of these will be used, not all of these will be used, but it's really to consider, depending on the needs of the program, which of these you will have to undertake. So for example, on the normative and regulatory, we know that in many cases, regulatory processes, regulatory reviews, inspections that may come with that can be quite time consuming. And so we're always looking for innovative pathways, utilizing pathways that maybe WHO or SRAs may have available, working actually hand in hand with the regulators to define that strategy. We do that quite often in discussions with regulators, and therefore establishing something that can be accelerated. On the manufacture and commercialization side, voluntary licensing agreements have been critical for access to medicines in low and middle income countries, so that the gap of a decade or more that has been observed over the years between an innovator medicine being approved in high income countries and a generic medicine being approved in low and middle income countries, that gap can be reduced significantly. So these are some of the things that we employ, and happy to take questions about those at the end if there are any. Next slide, please. So moving on to the case studies, the first one is lenacapavir. And so for any of you that may be familiar with the HIV space, lenacapavir is one of the more recently approved drugs. It was approved a little bit ago for heavily treatment experienced HIV positive individuals. More recently, it has been approved for HIV prevention. And it's really a groundbreaking technology and drug in that it is a six monthly injection. So twice a year, someone wanting HIV prevention gets their injection and they are covered. So it's really transformative. And so that has been approved in high-income countries. Gilead is the innovator of the drug. And so at CHI, with funding from Unitaid and working with Wits RHI based in South Africa, we have a program now to develop generic lenacapavir. So this slide really goes through kind of the reasons. You know, we are far away from the targets of HIV prevention, 1.3 million new infections in 2023. It's probably not going to get better with the significant US government funding cuts that we have observed over the last almost year. So we're very far off target. So with a twice yearly injection, it holds enormous potential. We have seen studies that have been done on preference. The evidence is showing that long-acting injectables are preferred across many, not all, but many populations. Long-acting products do offer greater protection per dose. Adherence is much higher than a daily oral dose, for example, and they can be highly cost-effective. Right now, they are not, but that's what we are working towards achieving. So while we have this great product that we are wanting to move forward and launch, it's not guaranteed that it will have as significant as impact as we would like. But we do need, a very coordinated supply and demand in the market shaping side of things to make sure that we can realize the potential of this product. Next slide, please. So how are we doing this? This kind of brings in a lot of those concepts from the market shaping slides that we previously showed. What we have done thus far is we have blended supply side interventions, which is the focus right now since the product is in development currently, as well as upcoming demand side activities, some of which do start while the product is still in R&D. So on the supply side, which is where me and my team are really most heavily involved, we do have an agreement in place now with one of the generic licensees. So if you remember on the previous slide, we had IP barriers as one of the possible barriers, and licensing being critical to overcoming that barrier. Well, Gilead did license lenacapavir to 6 generic companies. And then through a very competitive RFP process, we selected one of the 6 licensees with which to work using our Unitaid funding and under what's called Project Prep. So on the supply side, this brings with it financial support for the manufacturer, product development support from my team, regulatory support from my team, all in an effort to try and accelerate access and get through development as quickly as possible, utilize mechanisms under regulatory processes that can accelerate that time to market. And we've just put a snapshot here of when this deal was announced. And as you'll see, the deal also came with an agreed price of $40 per person per year, and that's for the injectable part. There is an oral dose required when initiating this, but for the injectable, which is what you would use to continue therapy, it's $40 per person per year, which is an amazing price and makes it affordable to governments, and it is at parity with the price of oral PrEP in the LMIC markets currently. On the demand side activities, other members of our teams at CHI will support ministries of health and communities to ensure that lenacapavir is rolled out as quickly as possible once the relevant regulatory approvals have been obtained, and provide training and get things into guidelines and get products adopted, and so on and so forth. And now I am going to hand it to Melissa to go through a case study that is probably near and dear to the hearts of the members on this call. So Melissa, over to you.
Great. Thanks. I think I unmuted myself. So Melinda, maybe you can give me a thumbs up if you, okay, great. You can hear me before I start talking to myself on mute. Thank you, Melinda. As she mentioned, the next and last case study that we wanted to talk through with this group was related to sickle cell disease. So through the generous support of open philanthropy, CHI was funded to transform SCD care in 3 countries, Ghana, India, and Nigeria. And through this grant, we aim to strengthen the global SCD ecosystem through 3 main goals, which are shown on the right side of the screen, by improving access through reduced prices, by increasing coverage of diagnosis, and then lastly, improving outcomes by increased enrollment in sickle cell disease care. And we've already made significant progress toward these targets, notably as shown on the left side of the screen. We were able to reduce the price of diagnostics as well as treatment for SCD through a deal with Silver Lake Research on the diagnostic side. We were able to reduce the price of RDTs, rapid diagnostic test, to just $1 per test. And on the treatment side, we were able to reach a deal with Qilu Pharmaceutical for a significantly reduced price for a quality assured hydroxyurea product. And although we have made this progress, there is still important work that remains to be done. So as part of this added work, Chai is working to further shape the market by establishing a sustainable global market for these products, also ensuring that the patient's voice is heard through community-based organizations, warriors, clinicians, and ministries. And then also, which Melinda spoke about a bit with the lenacapavir example, aligning commitments to ensure that there is a more predictable demand and supply. So let's take a closer look at some of the ways that Chai is doing this. All right, so similar, again, to the lenacapavir case study, Chai is working together across the supply side and demand side with interventions to help align commitments that really helps to establish a sustainable market and helps to balance the supply and demand equation. So the three categories shown on the lower portion of the slide of the interventions might look familiar, which is from our market shaping framework that Melinda shared earlier in the presentation. So to walk through those in a little bit more detail, on the left for research and development, for this particular case study, since there are already quality assured diagnostics and therapeutics available, our interventions on sickle cell disease are more focused on the other two categories listed here. As part of the normative and regulatory category, it is important to assure that not only are products approved by local authorities, but also that these products are included in national and WHO guidelines, which are necessary to ensure product adoption. For the manufacturing and commercialization category, Chai was able to facilitate the entry of new and quality assured suppliers to the African continent, which will help to increase competition and further drive price reductions of the products on the continent. And at the same time, we are working to establish partnerships with local suppliers to create that sustainable product supply. Okay, so that brings us to the end of the presentation. So we'll have plenty of time for Q&A. But just wanted to leave the groups with a few thoughts as we look to the future with all of the changes and evolutions that have been happening in the sector, which requires adaptation. So first, looking at adapting to declining external funding, we all will need to review our approaches to new product introduction and adapt. We're going to have to reconsider capacity building. We'll have to consider rollout of new guidelines, along with reduced support. How are we going to maintain sustainability? And we'll have to think about integration across different disease areas in order to be more efficient across our products, across diseases. We'll have to do the same or more with less funding. We also will need to institutionalize learning and knowledge sharing to help become more efficient. We'll have to think about how we're documenting new and improved approaches across these different product introduction frameworks. And we'll have to share this both with governments, with partners, with donors, and with our communities in order to ensure the accelerated adoption of new products. And lastly, we need to seek opportunities for cross-program coordination. Where can we start streamlining to reach those efficiencies? Can we streamline reporting? Or can we streamline procurements? and perhaps monitoring on shared commodities, for example, diagnostic platforms that might be used across different disease areas or across different facilities. And this can help us in turn to further reduce costs, reduce complexity, and hopefully find some efficiencies that we have yet to realize. So with that, that concludes our presentation today, and we'd be happy to take any questions. Thank you.
Thank you, Melinda and Melissa. That was awesome. Marjani, I'll facilitate Q&A if you don't mind.
Absolutely.
So I have a couple questions, but I can go last. I want to see from the audience if anybody has a question. It's a small group, so first come, first serve. Raise your hand however you like. Hermione. Please take yourself off mute. Do you have a question? I saw you raise your hand.
Yes, good morning. My question was, which three countries on the continent of Africa did you say that
For
this is?
for sickle cell?
Yes, I'm sorry for sickle cell.
Okay, there were two on the African continent, Nigeria and Ghana. The third country was India.
Okay, thank you.
You're welcome.
Melinda and Melissa, you covered the complexity of establishing a stable and dynamic and competitive marketplace. And much of the last few years has included discussion on local or probably more preferably regional manufacturing. And I'm curious what your thoughts would be on how Chai and others in the community collaborate with the newly launched AMA, headed by Dr. Mimi Darko, and the Africa CDC, which is in the specifically in the process of releasing a continental plan on sickle cell disease. So what are your thoughts on collaborating with those organizations?
Trying to get myself off mute there. So thanks, Paul. Thanks for that question. Certainly, those two organizations that you mentioned, AMA and ACDC, are going to be critical partners. And we are very interested at Chai in supporting them in their journey as they establish their systems. So thus far, we are having initial conversations. We've had various touch points along the various therapeutic areas in which we work. So I think for us thus far, the contact has been around disease areas outside of sickle cell. And I think you have had some conversations more recently regarding sickle cell. And I think this speaks to the integrated approach that Melissa mentioned. We want to make sure that if we are looking at collaborations and assistance, that we are doing that, a bit disease agnostic in a sense, because so many of the concepts will apply across disease areas. And there will be some, of course, that are very specific to disease areas. But I think what we are seeing with the launch of AMA and the launch of ACDC is that there's real progress now to standardize, to collaborate, to harmonize across the continent so that there can be then real progress against goals in therapeutic areas. Because I think previously it has been quite fragmented, and WHO obviously has played a critical role in a lot of that organization and harmonization. And I think now maybe that role will shift or should shift to these continental organizations, and they will have the input from their countries to be able to then establish their systems and profiles.
Thank you for that, Melinda. And it is early days, and I think it is going to require sort of the mantra that Chai has that this is a sprint and a marathon.
Mhm.
And so how do we apply a holistic approach so patients are receiving quality care now, and we have a more balanced approach to markets over time? I see Nkechi has a question, and I'll read it out loud. Or would you like to read it out loud, Nkechi?
Yes, I can. So I was wondering, in light of declining external funding, what strategies are you considering as Chai to ensure sustainability of these projects? And I have another question as well. Um, how do you manage to keep costs low whilst also ensuring profitability for the farms involved?
Thank you for those questions. Melissa, I'll take a stab at them and then please provide thoughts as well. So I think the critical piece is the balance between supply and demand that we mentioned as part of the market shaping framework. So that what we try and do is balance the right number of suppliers in any given market while generating demand. And I think the demand generation side is so important because building those markets so that they aren't fragmented anymore, establishing those, pooling those resources. And again, speaking back to Paul's question about AMA and ACDC, harmonizing those approaches is going to be really important. So, that is what we've seen over the years in HIV, for example. It was that coordinated effort, the consolidation of the markets, and HIV obviously benefited from large international donors. They still do, but getting to your first question about the declining external funding, what do we do now, right? When there aren't as many global dollars out there to be had. And so a few things that we are looking at is the evolution of the market shaping framework to be more focused on local or what we typically call regional manufacturing, bringing that manufacturing a bit closer to the patient. That's also in part a response to the interruptions and disruptions seen through COVID-19 with supply chains, but making sure that those prices can be kept affordable for the end users, for governments, and building that marketplace on the continent to reduce reliance on external parties, external manufacturers. And that's not going to happen quickly. It's going to take some time. I mean, obviously there are pharmaceutical manufacturers, many of them on the continent, but really trying to streamline that approach to build those markets. It's really about the business case and a portfolio of products, not just a single product. And so I think those are some of the things that we are considering moving forward. Melissa, anything to add there?
Yeah, just one other thing to add around the first question around the decreased external funding, what strategies there are. So I just wanted to build on what Melinda said and kind of circle back to that last conclusion slide. One of Chai's main strategies is that we're really just looking to find efficiencies where we can. So there are units at Chai that have been very focused on, given the decrease specifically in US government funding, which will, I think, end up trickling down to other external funding sources. What are the highest priorities? How do we triage? What does that look like? And then from there, combining those across countries to better understand which countries are sharing the same challenges, and then where can we find efficiencies to make those more scarce dollars stretch even further than initially anticipated. So through a lot of the upcoming grants that we're seeing, we're trying to build those efficiencies into those grant proposals and into the work that we're even already doing so that those dollars get stretched farther And a big piece of that, circling back to how Melinda responded, is around harmonization. Where can we harmonize? Whether it's technical harmonization, regulatory harmonization, guideline harmonization, that's really going to drive at some of these efficiencies as well. Over.
If you don't mind, I'd like to make one more comment because I know that in areas, conditions, diseases, and sickle cell disease might be one of those where the community is not as aware of these types of market shaping approaches. I often hear people talking about hydroxyurea from a particular innovator, and that being the price we have to endure, which is quite high. That's not actually true. The way Chai thinks about things is in high income countries, you primarily have value-based medicine. It's how much money are you willing to pay. In low-income countries, we take more of a cost-based approach and a bottom-up approach. So in Melinda's group, they have experts looking at patents to figure out the most cost-effective way to manufacture through advances in process chemistry. So we can get the cost of goods as low as possible. And then to what Melinda and Melissa said, that market then tells us how we shape the margin, the profit per capsule, if you will, so that this is a smart business decision on the point of from the viewpoint of the manufacturers, but it's also delivering the lowest cost product against quality assured standards. I'm going to turn. I see that Gail has her hand up, as does Marjani. So let's have Gail first.
Thank you very much. I'm the founder of a small NGO that is providing clinical care to a group of children in Western Kenya to try to stem the high mortality rate. And we have a project to show that we can reduce mortality from 70% to 40% through WHO interventions and primarily hydroxyurea. And we're showing startlingly good results so far. One of the challenges is the government is trying to, the county government, who has decentralized authority for healthcare. We've managed to dialogue with them, and they're interested in partnering with the CHAI to buy hydroxyurea at lower cost. And Paul, we need to meet on that, please, soon, because they are motivated and want to avail of that. One of my questions, though, is CHAI's policy of only dealing with governments. While this is understandable, I think it ought to be borne in mind that with governments, there is often there's a difficulty of the fact that the standards and accountability aren't there. So very often, the products may not get to the end users. And how do you know that they are? I think excluding not-for-profits from your partnerships could be a mistake because a lot of us are delivering real results and can show where inputs and outputs get to the end users right away. Whereas with national governments, it's very hard to monitor that unless you're doing it through organizations like the UN, through their technical assistance programs. So I'd invite you to please revisit your policy of only working with governments. Thank you.
Sure. I would add
Maybe-
and comment to that two things. One, there is a bit of horses for courses, Gail. We would interact in Tanzania, which goes exclusively through government, differently than we would interact in Kenya, which has, as you noted, county governments. And we also are being very active in working with major consortia like Sickle in Africa, CONSA, et cetera, to find ways to accelerate access to commodities. So it really is holistic. What we have learned, though, is in the end, the government is the major procurer in a country. And we try everything in our power to kickstart things. We do end up primarily working in the end with governments because they are the biggest procurer. But that we have a holistic approach.
Thank you.
You're welcome. Marjani, I knew you had your hand up.
Yes, I did. And it relates to the comment you shared with us earlier, Paul and Melinda, to your case study about lenacapavir. Um, so I think you touched on that long-acting products often carry upfront cost, but there's strong evidence suggesting that it can be highly cost effective over time. So I'd like to ask, what strategies does Chai recommend for helping governments and partners build confidence to invest in these products despite the initial price barrier? Or what communication strategies can you share with our smaller members that can um, talk to their government about this?
Yeah, thanks for that, Marjani. So um, this goes a little bit outside my area, and I think we have some on the line. So I would say I would kick it off by saying, and I'd maybe ask Elizabeth and or Brian to also weigh in here. But it's really about evidence generation. And so as I mentioned for lenacapavir, we are under a Unitaid grant called Project PrEP. And one main component of that is the work that WITS RHI is doing on the implementation science for long-acting products and actually more broadly HIV prevention products. But they are also gathering significant evidence on preferences. What we have seen at CHI, for example, through years of work in family planning, is that choice you know, is really required. The end users want choice that fits for, their life at any given point in time. And historically, that wasn't the case in HIV. It was, here's the red pill, blue pill, we used to call it. So we're seeing now that choice is much more relevant, and there are products coming through that allow for that choice. And so gathering that evidence through the implementation research and those studies is really compelling for governments. But to be honest, it's also really at the end of the day, primarily about price. And so bringing those other options through for governments to consider at a price that would be affordable to them then allows them to consider these other factors, like what portfolio of products do they want to be able to offer? Is that something that is important to them as a government, for example? But Elizabeth or Brian, from your perspectives, because you're much closer to this than I am.
I thought that was a great response, Melinda. I don't have anything else to add unless Marjani, you have additional follow-up questions.
No, Melinda, that was a great answer. Thank you so much.
Let me also give you a little bit of color because I heard something in addition, Marjani. Melinda noted that there is a tablet that has to be administered at the beginning of lenacapavir treatment. And so there might be a slight increase in price uh, for the government or the patient if there's any out of pocket for that for initiation. But there's also another consideration when a new product comes on board, and this is where working across many players is so critical. We often have what we call a launch price, which can sometimes be higher because there are costs that have to be accrued or recovered, and we're not as efficient yet. And then there's a scale price where we anticipate as we reach the real market demand, we have economies of scale, economies of time, and the price drops. And sharing that journey with governments gives them confidence that even if there are launch prices that are higher, they will see through volume and time prices that are more affordable, the quality remains the same, and that leads them to build confidence around sustainability. Gail,
Paul.
Gail, I see you have your hand up. Is that another question?
No, it's not. I'll try and find a way to put it down.
That's okay. That's okay. We'd be happy to answer another question. Anybody else on the line? Raise your hand or shout it out. All right. Well, this Eunice or Andrew.
There we go. Unmuted. Hi, everyone. Sorry I had to join this call a little late. Was in a few meetings this morning. Just curious, I was actually in Zambia last week where we were doing some trainings and discussions, and hydroxyurea came up. And I was curious what Shai's thoughts are. So when I spoke to our colleagues in Zambia, many of them spoke that they do get different types of hydroxyurea, some from India, some from Novartis models, European models, and so forth. Obviously, costs are differentiated between the bunch. And just curious what Shai's thought process around, measuring quality between different types of drugs. There was anecdotal evidence that some types of hydroxy were not as beneficial to patients in Zambia as others, and there's been some concerns over the fact that there's been some challenges there. So just curious, as Chai is working on developing these markets and working with different stakeholders, how to address the different types of product available, what's the most quality or one has best health outcomes, and how do you balance the cost associated with sometimes what might be seen as the better quote unquote product, if you will.
Yeah, thanks for that, Andrew. So that is something that we are, constantly discussing because we firmly believe that the quality of any of the medicines for any of the therapeutic areas in which we work need to meet a set of stringent standards so that patient safety is protected, efficacy is you can rely upon it. And so we are always looking at how to make sure that the products that we work on come with that level of quality assurance. One metric for that, obviously, is the regulatory reviews that the product undergoes. And so, as I mentioned, we work very closely with SRAs and also with WHO PQ. Now, not all products can necessarily go through those mechanisms. But when we engage with suppliers, and particularly on projects in which there is a product development component, we're also working with that supplier on their quality assurance and identifying gaps in their quality management systems, helping them to address those gaps, and making sure that once a product that we are working on with them would go under review, that it would withstand both the regulatory review process as well as any inspection process that comes with it. We know that many of the national regulators are also going through their own improvement systems, and this goes to the WHO process now to become a WHO listed authority. Prior to that process, it being an assessment of maturity level of the national regulator. And so we know that across the African continent, particularly, there's a wide range of maturity levels for each of the NRAs. And even within a maturity level for a single SR or a single national regulatory authority, there could be a wide range of maturity level for each type of product. So, for example, drugs versus vaccines versus diagnostics. And so, it's quite a complex system in a sense, but I think that what we are seeing is that those national authorities are moving towards improvement. We think that, the AMA particularly is also going to strengthen that. AMA is modeling themselves after, EMA because it's a very good model for them. And we hope that those regulatory systems improve so that the quality of medicines produced there can be more relied upon, because you're exactly right. And you've probably, particularly with hydroxyurea, have seen that firsthand, that not all hydroxyureas are created equally. So how do you figure out which is the better, particularly with government procurement, which relies so heavily on price?
Wonderful. Thank you. This is really helpful.
Thank you for that question, Andrew. Got about 9 minutes left. We could either hand that back to you, or if anybody has a last question, be delighted to field it. And if questions come up, most of you have my email address, and I'd be happy to bring in Elizabeth, or excuse me, anybody on the CHI team, Melinda, Melissa, Elizabeth, Brian, to answer your question on CHI's approach. We appreciate the opportunity to share what we do, and thank you so much for paying attention, and have a good day.
Thank you,
Marjani, back to you.
Thank you, Paul, for leading this call. Thank you, everyone, for showing up. And thank you, Melissa and Melinda, for speaking to us today. If there are any questions, please feel free to send them to our coordinator inbox. I'll pop that in the chat. But we'll end the call. Thank you all.
All right, thanks.
Thanks, everyone.
Thanks, y'all. Bye.